Now, let us take a close look together at this beautiful diagram of the knee joint, which here is being used as a representative model of a synovial joint. What you see in the image is an anterior view of the open knee, with the patella cut away so that we can peer into the interior. At the very top, notice the patella itself, sectioned to reveal its articular surface, which is normally covered in smooth hyaline cartilage. This cartilage, shown in blue, creates an almost frictionless surface, allowing the patella to glide over the femoral condyles during flexion and extension. Beneath it, the synovial membrane and the capsule are depicted in orange, lining and enveloping the joint, maintaining the sealed environment that makes synovial joints so unique. Direct your attention now to the femoral surface. The articular surface of the femur, like that of the tibia, is capped with hyaline cartilage. This is one of the most important features of any synovial joint because it is the cartilage, not the bone, that actually articulates. The bone itself, as you know, would be too rough and brittle to withstand repeated motion. Instead, this glassy cartilage allows nearly frictionless movement, distributing loads and protecting the underlying subchondral bone. When this surface degenerates, as in osteoarthritis, the patient experiences pain, crepitus, and stiffness, which all arise from the exposure of the raw, innervated bone beneath. Now, covering and protecting this articular environment, we find the synovial membrane. It lines the inner surface of the capsule and also covers ligaments such as the cruciate ligaments you see centrally here, so that they too are bathed in synovial fluid. Think of this membrane as a living filter. It draws from the plasma of the blood and produces the synovial fluid, which is an ultrafiltrate enriched with hyaluronic acid, lubricin, and other proteins. This fluid has two essential roles. First, lubrication. It reduces wear, allowing the joint surfaces to glide. And second, nutrition. It delivers nutrients to the avascular articular cartilage and to fibrocartilaginous structures, like the menisci and the triangular fibrocartilage of the wrist. Speaking of menisci, in this knee specimen, you see the medial and lateral menisci clearly labeled. These crescentic pads of fibrocartilage deepen the tibial articular surfaces, spreading load and providing shock absorption. Fibrocartilage differs from hyaline cartilage, whereas hyaline contains type 2 collagen and is designed for smooth articulation. Fibrocartilage contains type 1 collagen and is far more resistant to tensile forces, making it perfect for load-bearing structures such as the meniscus, the vertebral discs, and the articular disc of the temporomandibular joint. Now, surrounding all of this is the joint capsule, a tough fibrous sleeve that attaches at the margins of the articulating bones. The outer capsule itself provides stability, while thickenings of it form the capsular ligaments. In the knee, we can appreciate how essential these reinforcements are, especially given the joint's vulnerability to injury. Athletes, for instance, are prone to tears of the anterior cruciate ligament, the ACL, which lies within the synovial cavity but is not covered by cartilage. The synovial fluid, which we've already mentioned, is worth pausing on clinically. In pathology, we often aspirate and analyze this fluid in cases of suspected arthritis, gout, or septic joint infections. Its clarity, viscosity, and cellular content can tell us a great deal about what is happening inside. Even therapeutically, viscosupplementation with hyaluronic acid injections has been attempted in degenerative joint disease to restore lubrication. One more note before we step back from the diagram: the subchondral bone. This dense layer sits just beneath the articular cartilage, supporting it structurally. On imaging, subchondral changes are often the first indicators of pathology. On plain X-ray, it appears sclerotic, while on MRI, it shows up as low signal intensity. Bone marrow edema in this layer is a hallmark of many joint disorders and correlates strongly with pain. So, in this single image of the knee joint, we have before us the essential architecture of all synovial joints.
the smooth cartilage covering, the subchondral bone beneath, the synovial membrane producing nourishing fluid, the capsule giving stability, and specialized structures such as menisci or ligaments ensuring congruity. Together, they create not only mobility, but also remarkable resilience, which is what makes synovial joints the true marvels of movement in the human body.
Now let us build further upon our understanding of synovial joints by examining this next illustration, which presents the deeper structural layers of a typical joint and then transitions into the clinical concept of ligament sprains. At the top, you see a clean cross-section through a synovial joint. Focus first on the layered arrangement. The articulating ends of the bones are capped with articular cartilage, that smooth hyaline cartilage we discussed previously, which absorbs load and allows movement with minimal friction. Immediately beneath this lies the subchondral bone, dense and supportive, and further down the metaphyseal bone with its trabecular structure designed to transmit forces into the shaft. Around the periphery, the entire joint is enclosed by the fibrous capsule, a tough outer sleeve that blends seamlessly with the periosteum of bone. Inside this capsule, the synovium lines nearly every surface except the articular cartilage itself. The synovium is critical. It secretes synovial fluid, maintains joint homeostasis, and even covers structures such as menisci and ligaments within the joint. Speaking of menisci, you see them interposed between the opposing bony surfaces. These fibrocartilaginous wedges increase congruity, distribute load, and reduce shear. Together, this arrangement ensures stability without sacrificing mobility, which is the hallmark of synovial joints. Now, let us turn to the lower sequence of images showing the degrees of ligament sprain. Ligaments, as you know, are dense bands of type 1 collagen that tether bones to one another, either directly or via capsular thickenings. Their job is to limit excessive motion while still allowing the physiologic range required for function, but like all biological tissues, they can fail. In grade 1 sprains, shown on the left, the ligament fibers are stretched but not torn. The collagen bundles may show microscopic disruption, but macroscopically, the ligament remains intact. Clinically, patients present with tenderness and mild swelling, but the joint retains stability. This is common in minor ankle injuries. In the middle, grade 2 sprains depict a partial tear of the ligament, up to about 50% of fibers disrupted. Here, you may see a small hematoma and sometimes hemarthrosis if the joint capsule is violated. The joint feels lax on examination, and the patient experiences pain with instability, particularly under stress testing. This grade often requires bracing and physiotherapy to allow healing. Finally, on the right, grade 3 sprains represent a complete rupture of the ligament, with ends separated and significant bleeding into the surrounding tissues. The joint becomes grossly unstable, as in a complete anterior cruciate ligament tear of the knee. Hemarthrosis is common, and surgical reconstruction may be necessary, especially for high-demand patients. It is important to appreciate that ligament injuries vary not only by grade, but also by patient age. In children, the ligament is often stronger than the physis, so instead of a sprain, they sustain an avulsion fracture at the growth plate. In adults, ligaments themselves are often the weak link, so sprains and tears are more typical. In the elderly, paradoxically, the ligaments may remain stronger than osteoporotic bone, making fractures more likely than ligamentous injury. When considering treatment, the approach depends on both the severity and the specific ligament involved. Grade 1 injuries often need only rest and immobilization. Grade 2 requires structured rehabilitation. Grade 3 frequently demands surgical repair or reconstruction, especially in weight-bearing joints like the knee or stabilizing ligaments such as those of the ankle.
So, in summary, what we see here is not merely anatomy in isolation, but anatomy applied directly to clinical reality. The way the elegant structure of a synovial joint, reinforced by its ligamentous framework, can be compromised in predictable patterns of injury. Understanding these patterns is what allows us, as clinicians, to correlate physical examination with imaging, to stratify treatment, and to counsel patients about prognosis.
Now, let us focus our attention on this striking illustration, which magnifies the articular cartilage and its relationship with the underlying subchondral bone. What we are looking at here is not just a smooth surface, but a highly specialized tissue with complex architecture designed to withstand the enormous forces of daily movement. Notice the layered organization. At the very top lies the superficial zone, where collagen fibers are arranged parallel to the surface. This orientation is deliberate. It resists shear stresses that occur as bones glide over one another. Beneath it, we encounter the middle zone, a moderately sized region where the fibers are more random or oblique in their orientation, acting as a transition between shear resistance above and compression resistance below. The deep zone follows, where fibers are oriented vertically, perpendicular to the surface. This vertical alignment is crucial for resisting compressive forces, since it anchors the cartilage firmly toward the underlying bone. Separating this deep layer from bone is the tide mark, an ultra-thin, distinct line visible microscopically, which represents the transition into the calcified zone. This calcified cartilage serves as a transitional anchor, binding the articular cartilage firmly to the subchondral bone. And beneath this, of course, lies the cancellous bone, with its trabecular framework that absorbs and redistributes load throughout the skeleton. Now, if we read carefully the box below the figure, we see the essential properties of articular cartilage summarized. First, its function. It provides an extremely smooth, almost frictionless surface that allows articulating bones to move with ease, permitting pain-free range of motion. It is avascular, meaning it has no direct blood supply and instead receives nutrition by diffusion from synovial fluid. It is also aneural and alymphatic, which is why cartilage injuries are painless in their early stages, but also notoriously slow to heal. Regarding its composition, articular cartilage is predominantly water, up to 80% of its weight, which shifts depending on load and compression. With aging, the water content decreases, leading to softening, while in osteoarthritis, it may paradoxically increase. Collagen makes up more than 90% of its dry weight, predominantly type 2 collagen, which provides tensile strength, along with smaller contributions from other types like V, 6, 9, 10, and 11. Proteoglycans interwoven within this collagen network are the molecules responsible for compressive strength because they attract and retain water. However, their concentration decreases with age, which explains why cartilage becomes less resilient over time. Chondrocytes, the only resident cells, maintain this delicate balance by producing collagen and proteoglycans, sustaining the extracellular matrix. The zones, as we just described, are highly specialized. The superficial zone to resist shear, the middle zone with more disorganized fibers, the deep zone to resist compression, the tide mark as a dividing line, and the calcified zone anchoring cartilage to bone. This hierarchical structure explains why cartilage can endure repetitive forces for decades without failure,
until pathology sets in. But here lies the clinical problem: injury and healing. Because articular cartilage is avascular, its capacity for self-repair is extremely limited. Injuries that are superficial, above the tide mark, rarely heal adequately. Deeper injuries that reach into the calcified layer and bone may recruit blood supply and mesenchymal stem cells, but the tissue that forms is usually fibrocartilage, not true hyaline cartilage. Fibrocartilage is tougher, but lacks the same frictionless, load-bearing qualities, so the joint is predisposed to degeneration. In modern orthopedics, procedures such as microfracture surgery deliberately penetrate the subchondral bone, stimulating mesenchymal stem cells to migrate and differentiate into chondrocyte-like cells. This process aims to fill defects with fibrocartilage, improving function, though it is not a perfect replacement for hyaline cartilage. So when we look at this simple blue surface on the diagram, we must remember that it is a living, layered, highly engineered tissue, one of the marvels of nature. It bears our weight, cushions our movements, and does so silently and without complaint, until degeneration or injury finally reveals its importance in painful clarity.